Africa, we cry for peace. Africa.
I would like to call on the lead speaker for this session, Professor Albert Barrocas, to take his presentation now. Thank you. Prof. Barrocas, you're welcome to make your presentation now.
Dr. Albert Barrocas is a distinguished physician based in Atlanta, Georgia, renowned for his extensive contributions to the fields of surgery and nutrition support. He serves as an adjunct professor of surgery at Tulane University School of Medicine, where he shares his expertise with the next generation of medical professionals. A graduate of Emory University, Dr. Barrocas is a retired general surgeon who has held significant leadership roles, including that of Chief Medical Officer. His commitment to the advancement of nutrition in healthcare is exemplified by his charter membership with the American Society for Parenteral and Enteral Nutrition, WASPEN, where he has played an instrumental role on the board of directors and the board of advisors. In recognition of his exceptional contributions, Dr. Barrocas was honored with the inaugural Aspen Champion Award in 2019. Dr. Barrocas is also an honorary member of the Academy of Nutrition and Dietetics, formerly known as ADA, and has served on their board of directors, further highlighting his dedication to promoting nutrition as a critical component of patient care. With nearly 3 decades of experience as the medical director of the Nutrition Support Team, NST, at Methodist Hospital in New Orleans, he has been a passionate advocate for the integration of nutrition support into clinical practice. Throughout his 5-decade career, Dr. Barrocas has focused on the essential role of nutrition support teams in enhancing patient outcomes. He is a proponent of adapting to shifts in the scientific, clinical, educational, healthcare, sociological, and financial landscapes, emphasizing the importance of inter- and transdisciplinary teamwork. His foundational framework, known as the troubling trichotomy, underscores his innovative approach to nutrition support and patient care. Dr. Barrocas continues to inspire healthcare professionals and students alike with his commitment to excellence in surgical practice and nutrition support, making significant impact on the health and well-being of the communities he serves. Ladies and gentlemen, special delegates, it is my singular honor to present to you the keynote speaker at the 2nd Annual Malnutrition Awareness Week of the West African Society of Parenteral and Enteral Nutrition, WASPEN, Dr. Albert Barrocas.
I want to thank Dr. Pounds. I want to thank the Society for allowing me to provide this presentation. In just a short order here, I will get us going. I've been very impressed with the work that WASPEN has done over the last 2 years. I took some planning from Dr. Pounds, who was a colleague of mine at the Atlanta Medical Center that recently closed. She's certainly a leader, not only in the local area, but internationally as well. I do have one difference of opinion from Dr. Pounds. I saw the very nice press conference release yesterday where she refers to malnutrition as an epidemic. I take issue with that because malnutrition is more than an epidemic. It is a global pandemic. So it's not just limited to Nigeria or West Africa. It's a global concern that has plagued us for many, many years. And unfortunately, we have the solutions to ameliorate the effects of malnutrition. but we're plagued also by lack of concern, in some cases, total ignorance. So, without further ado, let's proceed with what I think are some of the topics that I'd like to address in my short presentation today. I think that we need to outline the basic micronutrients, macronutrients, and their role in short and term starvation and stress very briefly. So we have a starting point for all of those. For some of us, it will be a review. For others, it'll be something new. And then look at various tools that we have, including the Global Malnutrition Composite Score that is being used here in the United States, and also that a similar profile is being carried out by the international group that is working on improving nutritional care and establishing it as a human right. And then talk about successful nutrition support teams, interdisciplinary and transdisciplinary teams. And lastly, leave you with some of my thoughts of the concept of T3 or the trouble trichotomy. Now, I go back to Stephen Covey, who provided various lessons to organizations and how they should function and succeed. And I'm a big believer that in order to be understood, first you must understand. And you do so with a sympathetic ear and with empathetic listening. And I hope that because we have a multitude of varied constituencies on this webinar, that you will take the time to understand the others and understand their goals and speak their language and use their terms so that you could be better understood and we all can be better understood. So, again, I think just from a very basic starting point, and I'm not going to go into great details, we need to recognize that while we have abundant fat stores, we have limited protein that we can spare, and we have hardly any of the glucose stored as glycogen. So that in about 18 hours of being NPO, we lose our glucose stores completely, except for a small residual that remains in the muscle and liver, and that can be exhausted with some exercise. So what happens when we fast? When we fast briefly, that is 0 to 7 days, we see a shifting of fatty acids for the most energy use by the rest of the body. However, there's an obligatory demand for glucose by the brain, the renal parenchyma, as well as the red cells. Excuse me. And that need has to be met by precursors to glucose. Fat cannot be converted, although there's a small contribution once the fatty acids are lysed from the triglycerides of the 3-carbon glycerol. However, the majority of the new molecules come from protein through a process that we all know as gluconeogenesis. Now, that protein comes from muscle, but it also affects the visceral proteins. And while we have a very nice graphic here of muscle, I remind you that the heart and the diaphragm are muscle as well. In brief, fasting, this rapidly transforms after the first week or so to prolonged fasting. And here is the reason why many individuals who have starved themselves, say for political reasons or what have you, for many weeks are able to survive. And that reason is because after a week or so, the brain which is the one that draws on the gluconeogenesis, becomes keto adaptive and begins to use ketones. Otherwise, at the rate of catabolism during brief fasting, you would be dead within 1 to 2 weeks. Now, when we are traumatized in a hospital, when we are stressed with infection, sepsis, um, trauma, burns, etc., we have the same thing going on with that added stress of the flow of hormones that have a tendency to mobilize a lot of the substrates for the flight, fright, or fight type of reaction that Dr. Cannon taught us many, many years ago. Plus, we need glucose for the repair of tissues. This very rapid deterioration of our very precious protein stores can lead to death within a couple of weeks to 3 to a month. And we see this in our critical care areas following successful recovery, say from a trauma, lung injury, etc., unless we pay attention to the nutritional status of that patient, regardless of how good the hands of the surgeons are and the good Lord has helped you survive a traumatic experience, you will die. So, with persistent hypercatabolism, we lose muscle mass, we lose visceral protein, and we lose organ function, immune response that leads to multiple organ failure. And many years ago, it was discovered that if you lose 30% of that precious protein compartment, for which there's no single gram of protein to spare, you have 100% death. In the community, you will see with the white arrow here that the gradual decrease of these protein stores results in symptomatic signs that show fatigue, weakness, being bedridden, apathy, depression, and then leading not only to the 30% nitrogen death, but also energy death. And one thing, if you look at the lower part of the slide here, to remember is that malnutrition often mimics the aging process. And so I want you to understand that aging is a process, not a disease. And you may mistakenly look at an elderly person and think, oh, this is happening because they're aging. You must not ignore the potential that in the majority of elderly individuals, even in the community, over 50%, regardless of whether you're in Nigeria or whether you're in Atlanta, Georgia, you will have signs of malnutrition.
Thank you so much. Thank you. It's amazing. You can see the applause coming from the floor. Really great here. Dr. Albert Barrocas has set the stage. At first, when the lecture was going on, I was actually taking plenty of notes. And I think, as a moderator, I would like to tell you some of my jottings, which will help us to understand the message that Dr. Albert has given us this morning or afternoon. He started by telling us what happens when we fast. And the fact today has been able to tell us why we're able to survive prolonged fasting as a result of keto adaptation by the brain. And he did liken malnutrition to aging. As no wonder when people are malnourished, they look old. They look older than their age. So actually, some of the elderly people we see are also being malnourished. And Dr. Barrocas did let us know that protein and protein energy or calorie malnutrition is a global pandemic, not just epidemic in Nigeria or West Africa. And he said that the most vulnerable groups are hospitalized patients, are the elderly, are the pediatric, and then we have it in low, middle income countries. He went further to tell us that individualized nutrition care should be evidence-based. And one of the takeaway messages is that this evidence should be provided by the local nutrition support teams. So that's a role for our nutrition support teams in our facilities to provide local evidence for the services or nutrition support services they render.
It is my pleasure to be among the speakers at this year's WASPEN second annual Malnutrition Week, where we are gathered to discuss on the very important issue, integrating nutrition care into the Nigerian healthcare system. I will be sharing the updates and of government efforts towards improving clinical malnutrition services in the country. Dr. Barrocas extensively talked about the current high burden of malnutrition in Nigeria. We are all aware that malnutrition is not just a statistics. It is a child being too weak to play, seeing a mother too tired to care, seeing a patient who should have recovered but did not. Malnutrition is a silent cause of preventable death. It steals lives every single day, and it leads to poor treatment outcome. Globally, whenever malnutrition is discussed, the focus is often on community challenge and hunger. But available evidence has shown that in the health facilities, nutrition can no longer be treated as an optional add-on. Nutrition must move from the margins to the mainstream of healthcare because malnutrition is also a very critical clinical challenge. Distinguished ladies and gentlemen, in Nigeria, malnutrition remains a silent but devastating emergency affecting maternal health, child development, and increasing the burden of both communicable and non-communicable diseases. The health services in Nigeria are provided in 3 levels: the primary, the secondary, and the tertiary levels. And at each level, we have seen cases of children admitted with infections, mothers that are admitted in maternity wards, and surgical patients get better whenever the nutritional care is included in part of their treatments. So the federal government of Nigeria has recognized that nutrition is a life-saving intervention that must be integrated across all levels of care. If we are to reduce preventable deaths, shorten hospital stays, and improve treatment outcomes, and truly achieve the universal health coverage, then nutrition must move from the project-based intervention to the system-wide institutionalized clinical nutrition practices, not only in Nigeria, but globally. So distinguished participants, you may now want to ask the question, what are we doing in Nigeria to institutionalize clinical nutrition into our healthcare system across all levels, from primary, secondary, and tertiary? At the primary level of care, which is the closest to the family, to the individual, we are integrating routine nutrition screening and counseling into every primary healthcare consultation. We are training the health workers, the community health workers, the nurses, the midwives, and also the volunteers, not just to identify malnutrition, but to act early, to conduct early detection and refer appropriately to where the desired treatment will be obtained. We are incorporating nutrition services into other primary healthcare services like immunization, antenatal care, family planning, non-communicable disease prevention, and health campaigns. We are ensuring that there is steady availability of therapeutic and micronutrient supplements to increase access to treatments. We are ensuring that nutrition services are explicitly covered under the basic healthcare provision funds. At the secondary level hospitals, we are ensuring that nutrition units and corners are established in all the general hospitals, backed by multidisciplinary nutrition support teams made up of nutritionists, dietitians, doctors, nurses, pharmacists, to mention a few. We are ensuring that there is compulsory nutrition assessment for inpatients and outpatients at admission, and we are standardizing nutrition protocols to ensure uniformity in malnutrition care. Likewise, the reference linkages between the primary healthcare centers, the general hospitals, and the community is being strengthened to ensure that no case of malnutrition slips through the cracks without being detected. We are providing continuous professional development for healthcare providers on nutrition, and we are also establishing specialized nutrition clinics for non-communicable diseases and malnutrition. At the tertiary level of care, that is the teaching hospitals, the specialist hospitals, and the federal medical centers, we are ensuring that the tertiary hospitals lead by example. So we are establishing where there are none, and we are expanding where we have limited support, the clinical nutrition and dietetics departments. We are strengthening the dietetics training, and we're generating local research to guide national policies that are currently being reviewed. We are making nutrition assessment mandatory for all inpatients, and we are providing opportunities for structured training, making the tertiary institutions a training hub for lower level facilities and policy advocacy platforms. The tertiary institutions are being strengthened to provide structured hospital feeding services to complement treatments, and also to provide advanced services such as the parenteral and enteral feeding. Likewise, the tertiary institutions, we are ensuring that nutrition will be mainstreamed into the medical, nursing, and allied health facilities curriculum.
This is awesome, Director. Really now this, I was just listening to these policy statements by a responsible person. You are the one in charge, and all this coming from you that government has recognized clinical nutrition as a problem, not just a problem that requires intermediate attention, but it has been mainstreamed into the healthcare, at all levels, primary, secondary, and tertiary. You have a policy statements, and you have advocacy statements, you have training programs, and so on and so forth. We have recorded all this because, I mean, these are things that we're not going to toy with. WASPEN will certainly get back on each of these specifics. And I'm sure during the question and answer time, the participants would want you to, elaborate on some of the statements that you have made. We really appreciate your making time to be with us and also taking this seriously. I'm particularly happy. I'm sure even Dr. Reza Pans will be happier than myself hearing all this good news from you.
I feel very honored and privileged to be among such great minds and to listen, first of all, to Dr. Barrocas, his excellent presentation, then my sister, the director for nutrition, Barco, it's really great. I feel much better. And going back to the Ministry of Health, their strategy is very clear, although I knew it before, that we had a very strong partnership relationship. But the presentation I had this morning has clearly outlined what is being done, and I can clearly see where WASPEN can fit in terms of continued collaboration. I guess the question would be, how can WASPEN strengthen that collaboration with the ministry? Of course, hopefully we'll hear from the NMA and Nutrition Society to create, a united front on integration. We all have the same goals. And I would like to say that the real strength will lie in uniting under one agenda, which I clearly heard this morning, just listening to my sister. For us, that means aligning with the Federal Ministry of Health so that nutrition is reflected in policy and backed by government prioritization. I think we heard some of that from her. That is a huge priority. And they're looking at, getting this incorporated in the policy. It also means that working closely with Nutrition Society of Nigeria to share evidence, drive research, and ensure guidelines reflect both science and local realities. I heard that a lot of what WASPEN is pushing for apparently is being done in some institutions. She clearly explained, the primary, the secondary, the tertiary. So the next step probably will be, can we have continued education? Can we have continued monitoring? And so, because when you monitor, then you can identify maybe some gaps, some strengths, and that work continues. So that would be one thing. With the Nigerian Medical Association, the focus is on getting, physicians to see nutrition not only as an optional extra, as said by the director, but also a standard part of patient care. So I believe for WASPEN and for me as the president, looking ahead, we really envision a system where these partnerships don't continue, don't just cooperate occasionally. I want to stress that, occasionally, but co-own the agenda, develop shared protocols, and becoming to embedded, have them incorporated in hospital systems, and also advocate together for policies like inclusion of nutrition in the National Health Insurance Scheme, which she mentioned, and the essential medicines list. So by speaking with one voice, we can accelerate national adoption and make integration real at the bedside. So I think those are the main points I want to make at this point. WASPEN is looking forward to continued collaboration, working with the Ministry of Health, collaborating. As you all know, we have the partnership with, working also closely with ASPEN, international organizations that can support us. And I think together, with this being done, I don't see why we cannot continue to move.
I have a
Yes.
question. How many other countries are joining this webinar today besides Nigeria?
I know we have 3 countries that are now planning to join WASPEN and have WASPEN chapters in their respective country. Ghana is one. So I think there's a Ghana representative. I know I saw her initially. And then the other one is Cameroon. And the third one is what's that? Uganda. Okay, those are 3. But the ones that are seriously considering starting the chapters, actually, the 2 out of the 3, Ghana and Cameroon, and they all part here. And WASPEN's goal is by the grace of God, sometime next year, we should have at least finalized everything and started the chapter in at least 3 West African countries. And I'm sure Ghana and Cameroon will be 2, so that is WASPEN's goal.
So, Dr. Barrocas, what's the fate of GMOs in this whole conversation about clinical nutrition? GMOs in this whole conversation that we are having.
That I am not an expert on.
Oh, okay, that's fine.
I will yield to my friend, either the Minister of Health representative, that's a dietitian, or to my good friend, Dr. Pounds.
Thank you so much for this wonderful presentation, Prof. Barrocas, and the nutrition director from the Ministry of Health. So, talking about GMO, I think right now there is so much controversy about its its health benefits and implications. And then there's a lot of discussion about the seeds, not being reused and all of that. And then the safety of the consumption of the GMO foods. And then the food scientists, the Nigerian Institute for Food Science and Technology, they are, somehow still in a huge research, trying to find out the effectiveness, although it promises some, turnover in yield and food security, but then the safety aspect is still ongoing, and there is no, a vivid conclusion on that. But what I know that is being supported is food fortification. Food fortification using some hybrid stems to produce some staples like cassava, now having a vitamin A fortified stem to improve micronutrients in our staples like garri and all of that.
Dr. Barrocas, you have a question here. It says, thank you for the excellent presentation. Will it be right to say GLIM is only used for confirmation of diagnosis and not a primary screening tool? And the second question, for the phenotypic criteria, in the absence of standardized ethnicity/demographic adjusted BMI, can the generalized threshold subserve?
I will give you my opinion,
Yes.
but I would ask the questioner to check with the literature, because the GLIM criteria continue to be revised, and initially ESPEN, the European Society, has modified it somewhat. But I think that the BMI numbers have to be adapted to the area, so that you may have a different BMI chart than what the World Health Organization provides in a generic fashion. Certainly, there are some phenotypic changes that occur in different societies, and that has to be accounted for. I think that the Glenn criteria is still evolving. I read an article just about a week ago where there was a discrepancy between the SGA and the Glenn criteria, where the SGA was more predictive in terms of malnutrition and particularly mortality. So, but again, it's a matter of using a tool that you can use in your particular environment. And one should not be limited just to the one Glim criteria, for instance, or SGA or some of the other assessment tools. I think throughout, if you look at weight loss, if you look at a dietary history as far as appetite and how much someone has taken in over the last week, those are usually indicators of at least not necessarily diagnosing a particular malnourished state, but certainly who is at risk, and take into account the underlying cause. Is this a chronic inflammatory process that will show us that white arrow where the decline is slower, or is it something that requires our attention right away as someone that just came in, say, with a third-degree burn in 80% of the body or what have you? I would like for Teresa to briefly talk about all that she did at Atlanta Medical. How did she get, just briefly, because she's been there for a long time. How did she get from just being part of the pharmacy department to being this great leader that she was, and the respect that she gained? How does someone transitions to that level if they're in a small hospital, say in Nigeria?
I felt like, as a pharmacist who is aspiring to be a specialist in nutrition support, that I can provide more, support the physician more by doing more. And how did I do that? I sacrificed almost a whole year. I was in that institution 12, 14 hours every day. I was developing relationships with medical doctors, with nurses, with pharmacists. Although I was doing my residency, but I was doing way more than that to get myself. My goal was, by the time I finished, I was going to change that service from a monitoring to a management service. What does that mean? That means I will be more involved. I will be viewed as somebody who is knowledgeable in that field. I will be viewed as a consultant. And my goal was any patient that got admitted to that hospital, once that patient has been screened and has gone through nutrition assessment, and the physician deems that the patient's gastrointestinal tract is not working and needs parenteral nutrition, that my service will be automatically consulted. And it took me a year. And I'm here to tell you guys, that's how I got it to that point to be.